I'm Katie Peeler. I just came from Boston, so thank you so much for having me. And I want to talk a little bit about ethical considerations in conducting research with migrants and asylum seekers. My perspective is from the US side, but obviously people that I work with are not coming from the US. And so just to put that in context. And so just to back up a little bit to kind of say how I got here and where I am, as I'm sure everyone in this room knows, Paul Farmer, but 20 years ago was when maybe 5 years ago was when I was introduced to his works when I was taking a medical anthropology course as a post-baccalaureate pre-med. So I majored in history in college and then decided to go to medical school, and so went back and did some more work. And I was probably the only person in the whole class that read every single reading and every single footnote because I was just really kind of blown away by what the works said, but particularly his. And one of the things that he wrote in one of his books called Infections and Inequalities, which is not this book, but he said, and he was talking about women with AIDS around the world, he said that what they share is a social position, the bottom rung of the ladder in inegalitarian societies. And I think that really struck me because I had grown up on a very different rung of society. I had two physician parents. I went to public school, but had everything I ever needed in terms of food and housing, and could go to camp in the summer if I wanted to. And I wasn't worried about my safety. And I just thought a lot about why that was and decided that it mainly was luck, like I was just, that's how I was born. And I, had this community that was able to help me, and it just didn't seem, I was very curious about why that was and why other people were on different rungs of this ladder and how we could potentially change it so there wasn't a ladder. And so that drove me to a lot of questions about health and human rights in general, and specifically as I started kind of getting involved within organizations, I joined the nonprofit Physicians for Human Rights, which is based here /DC /Boston, that does a lot of what it sounds like it does, but they really do evidence-based research to try to advocate for the rights of people as they pertain to their health around the world. So they don't do direct patient care, they really do human rights investigatory work. And I became mostly interested in immigration and asylum seeking, frankly, because eventually as a physician, it felt like that was the most tangible thing that I could work with. So I felt like I could examine people who are seeking asylum and lend credibility to their asylum case by kind of discussing the evidence of what had happened to them in their home country. So I did a lot of forensic evaluations, examining people physically and saying this scar is consistent with this mechanism of injury that they suffered in their home country. So it was a lot of forensic medicine. I did that for a very long time, and I liked that, and I taught that, and I continue to teach that to various kind of clinicians. But I continued to kind of wonder about the why, though. Why are people seeking asylum? Why? What's going on in their home countries? What's happening to them en route? What's happening to them when they reach our country, where conditions sometimes almost seem worse in our detention centers than what they've left, depending on the person. And so I've really more so switched into doing research that directly informs advocacy efforts. I'm definitely kind of an applied researcher. I should also say I'm largely an unfunded researcher, so very different than kind of this. I cannot give you any advice about applying for grants because I've never applied for a grant in my life. But so if you advice from me, feel free. But so I've always just kind of self-subsidized, which I would not recommend, by doing extra clinical work to kind of to basically support my life, and then doing my research kind of almost on the side. And so that's kind of where I am. I don't and I have felt all along that these are kind of the things that guide kind of all questions in terms of research, but particularly for me, what matters to me, what matters to the person in front of me, what matters to that community, what is the matter, so what's the problem, who cares, so who does it matter to, who should care, right? Like I care, maybe you care, but I also feel like this policymaker should care, so how do I get them to care? Why should they care? That's really important, and actually the focus of some work I'm doing now. And then basically, how do I bring that all together? How do I show what matters, what is the matter, and convince others to care and to act? And so we'll get to this in a minute, but I essentially, since the pandemic started, I started working with a bunch of medical students and now students in a lot of other the graduate schools at Harvard to form this kind of euphemistic immigration lab. It's not a place, but it is a group of us who have kind of come together to research questions as they pertain to the health and health rights of people who are detained in the United States, so people who are basically in immigration detention, largely adults, so mostly in ICE detention, or potentially in before you are in ICE detention, you would be in Customs and Border Patrol detention, and a little bit with children who are in the Office of Refugee Resettlement. But really looking at those health conditions. And so our lab, our kind of mission is really to look at questions that are important to the health of those populations and try to inform policy related to the health of those populations. In terms, and I will tell you that I'm not going to tell you all the results of my research because I feel like that's, although I think it's interesting and fun, it's not really the point of today. It's really to talk about kind of how I did the research that I did and why I did that, and some of the issues that came up, which I'm sure many of you have also had. And so one of the readings that I assigned was this McLaren study, which you may have had a chance to read, and if you didn't, also totally fine. But I just want to talk about a little bit. So this study was done by researchers who had actually done research understanding kind of the mental health kind of challenges of Haitians who had migrated to other countries, and then some have been deported back to Haiti. But this study actually was not about the study per se, but about kind of the ethical considerations that they had either thought about in advance or kind of encountered as they started to create the methodology and actually to roll out the study and afterward. And so I thought there were some really important points that I want to talk about first before we kind of get into some of the research that I have done. But one of the points that they talked about was how the research of migrants it's somewhat uniquely different in the sense that you're navigating tensions between the need for research transparency, as well as replication and accountability, all the things that you guys have been talking about this week, as well as the ethical responsibilities to the research participants, who are different in the sense that they're in a system that doesn't always acknowledge them. And the system is very complicated because it crosses borders, it crosses agencies, it crosses family dynamics and lots of other things along those lines. And they talk a lot about in this article about the legal precarity of these populations. So the populations that I work with in the United States are people who are primarily in detention. And the way that you kind of get to be in detention is that you either come to the United States seeking immigration relief of some form, sometimes it's asylum, sometimes it's something else, and you don't have the proper paperwork to otherwise enter the country, you don't have a visa or things along those lines, and you're put into detention kind of while you're awaiting your asylum proceedings, while they're deciding kind of how to move you forward or to deport you. Or you've already kind of gotten to the United States either on a visa that's expired or because you've snuck into the United States without being noticed, and then either because of a traffic violation or a workplace raid or something else, you've then kind of come to the notice of the authorities, who then puts you in deportation proceedings, and then you go into detention while you're waiting for that. You might ask for asylum at that point in time, but you'd be in kind of an adversarial process because you are asking for asylum after you've already been put in deportation proceedings. And so you could imagine that doing research in these populations, there's a lot of legal precarity. Some people have status, right? They are actively seeking asylum. The United States government knows that, and so you are allowed to do certain things, and you have certain rights and certain abilities to work and whatnot. Or potentially you had some status and it expired, or you didn't get it and now you're here without proper paperwork, or you never had proper paperwork, or maybe you have proper paperwork but your spouse doesn't. And so there's a lot of complications and legal precarity with these populations. And as a result, they talk about this article how there is a very, very powerful power asymmetry between the researchers as well as the participants. And that's true, right, in any research population, even if you're working with, wealthy Upper East Side cancer patients and there's still a power asymmetry. You are still the researcher, but this is particularly true in this population of people who are not totally sure if they participate in your research, what it will mean for their legal status, and if something negative will happen as a result, either to themselves or to someone else that they care for. She talks a lot about the importance of including participant communities in the study decision making, which I know several of you wrote about in your abstracts about already having community advisory boards. She also talks about the uncertainty. Doing this research can change at any given moment because of the changing socio-political kind of conditions in our country and in other countries, right? Like our country feels very different today than it did even a month ago, right? And so, and that really influences how this research works, because it influences not only your research and your ability to get grant funding, but it also influences your participants' decision. That someone who said yes a month ago to doing your study may now say, like, I don't think so, actually. Like, I thought yes, but now I'm going to say no. And so it can change really rapidly, which may not be quite as true in other populations. I think those are the main things that I wanted to talk about from this particular paper as they kind of inform what I'm talking about. But I think for me, the most important part in terms of ethics and doing ethically informed research with migrant populations is that we're all here because we all believe that there should be robust research ethics with our studies, right? Like everyone knows that, we all agree. But I also think that while that's important that it inform all aspects of your potential study, the only way to actually uphold those standards is to be really meticulous about your logistical considerations. You can have like lofty ideas as much as you'd like, but if you can't accomplish them, then you can't really move forward. But I will say, I think there are creative ways to, which is the whole point of this week, but there are not necessarily creative, but there are ways to uphold the ethical standards that you want. You just might have to either be creative or to understand that there's resources that you aren't aware about, or talk to other people that you don't realize are actually important to your study. And then the other thing I want to talk about is thus that, and I mentioned this earlier, that migrants are really part of a system. And they're part of like a really broad system. So they're part of a immigration system in this country as well as their home country. They're part of a system related to just mass migration in general and climate change and how our country's politics influence other countries' politics, and a historical system. They're part of family communities. And they're part of a system of labor, both kind of official and unofficial in this country and elsewhere. And so they're part of a system of an economy built based off of migrants moving through Central America and people being able to sell food to migrants who are on the move. And so there's just a lot of systems that migrants are part of that, again, every person in any study is part of a system, but their systems are a little bit more unseen and a little bit more changing. And so all of these things can influence your research. And so kind of moving a little bit into to what we studied. So in, let's see, February, I think, of 2020, a group of students, medical students, and I just started essentially saying, it'd be really nice to know what's going on in detention centers in the United States. With COVID, we suspect it's not very good, but we have to prove that, as is true in any prison and jail setting, any carceral setting, right? But we were particularly interested in immigration detention. And so some of the students who I work with are really wonderful with large data sets. That's not my area of expertise. My area of expertise is content, but they downloaded tons and tons of data from ICE, Immigration and Customs Enforcement, as well as kind of the US, the CDC and other sources, and compared essentially the case rates in immigration detention compared to the general US population. And even though I'm not a visual learner, this is a pretty obvious graph, right? That it's it was much worse in ICE detention in terms of the case rates of COVID were just astronomically higher, which was not really surprising. And we thought we knew why, but we wanted to understand. We wanted to make sure that we were right about the why. And so this first report, which was a joint effort between myself and basically 3 medical students, that was our kind of group. And then we partnered with Physicians for Human Rights, and I will get to that in a minute, to produce this report. We did all the research, but they helped with the kind of the report promotion, I should say. Is that we ended up interviewing 50 people who had been detained in ICE detention sometime between, they had been released between March 16th, which was a couple days after it had been declared a national public health emergency in the United States, and August 12th, 2020. They were across 22 different facilities, both kind of private. A lot of ICE detention facilities are run by private corporations as well as public ones, which jails often will subcontract with ICE to hold people being detained by ICE. in 12 states. And the way that we decided to do this is that we took ICE's own protocols, their own protocols about how to handle public health emergencies, and then specifically how to handle COVID, which they had written rather rapidly, understandably, right? We were all writing our policies rather rapidly and changing them every 5 minutes, in fairness to ICE. But we took their policies and then we just turned them into questions to understand what was really happening there. And this is the map of the different places. And so again, I'm not gonna actually go over the results. I will tell you that they were not surprising, right? Like there was lots of crowding, no access to testing, no access to medical care, lots of retaliation if you did complain about anything. You were placed in solitary confinement instead of medical isolation, like just lots of bad stuff. There was literally the most common reaction to the hand sanitizer question was laughter, because there was just no hand sanitizer. There was soap, but not frequently, which is why the title of this was Praying for Hand Soap and Masks. That was a direct quote from someone. But I just wanted to talk a little bit about the methods for this study, and then we'll go to the next study, because I think this is where some of the ethics come in. And so when I walked in, I think you guys were finishing up a conversation about the IRB. And so hopefully nothing I have to say is in direct contradiction to what you were talking about. But we knew that this was going to be a very fraught study, right? We were going to be talking to people who are have different legal statuses in the United States, who are detained by the U.S. Were detained. They were no longer detained, but they were at risk of being detained again at any given moment. Who were probably didn't have a whole lot in terms of work, in terms of resources, and just had a lot of potential limitations in terms of discussing with them their thoughts safely. And so we developed our study, but before we actually submit to the IRB, we reached out to the IRB. And so I'm not sure if this is what you were talking about earlier, but we found it extremely helpful to reach out to the IRB first and discuss our general study and review our general plan to get their input before we submitted it, which actually they had, and it was very helpful because they actually had excellent ideas. They had much better ideas than we did about how to both protect subjects as well as to get the data that we needed in a very rigorous fashion. And they really pushed us appropriately on some things like, do you really need that piece of data? And you're like, oh, I don't. Or like, do you really need to ask that thing, or is this thing important? And so some things we knew about, separating data and making sure that there was no way to link things like that. Those stuff were obvious, but the things that they had suggested that hadn't occurred to us were that basically we got no identifying information. And I think that kind of blew my mind at first, and I realized that I really did not need it at all, especially for a one-time study, right? We weren't going to be doing follow-up with individuals. And so the way the IRB suggested, the way that they actually suggested it ended up being exempt entirely, which also blew my mind. And so we actually didn't ask any data. We created a script for immigration attorneys. We recruited participants through immigration attorney listservs, so basically mostly nonprofit attorneys or attorneys taking cases pro bono. And so it was certainly, a biased sample in the sense of kind of how we were able to get persons, had people who had legal representation, although they were able to also refer other people. And we couldn't control who they referred. But the way it worked is that they would then, the attorney would reach out to us after they had asked the person if they wanted to participate, and they would give us just their phone number. They would give us their phone number and their preferred language, and that was it. And then we would text that person via WhatsApp and kind of say, we're from this Harvard study, your attorney had told us you might be interested. If you're still interested, let us know and we can give you a little bit more information and do informed consent and things along those lines. But we never actually knew anyone's name. We never knew where they were located. Certainly you potentially could track someone down by their phone number, but their phone numbers were kept separate from the actual data set that we were keeping. And then we deleted all the phone numbers and all the text chains thereafter. We used WhatsApp specifically as opposed to other kind of features, because at that time that was felt to be a kind of safe and encrypted way of communicating, and also just more universally accessible. It was great. And I will say the other kind of thing that came up was what to compensate people for. And I think you either talk about this later in the week or already did, but I know it's on your agenda. And I will say that while we did not have a community advisory board for developing the study per se, we certainly had a community advisory board of immigration nonprofit advocates who helped kind of inform how we thought about both outreach as well as what the ramifications of the study would be before we did it, as well as compensation. Because we certainly were not comfortable offering nothing. That felt inappropriate, and like we would be using people for their time where we would otherwise compensate other people, but we also didn't want to be too coercive or more than you would necessarily compensate someone else for a similar study. And so we ended up offering $40, and we felt that that was appropriate in the sense that it was going to be we assumed that the average length of the interview would be around 2 hours, and we felt that $40 would be either the amount that you could cover for if you like paid for that person's lunch, they were like coming in to first and their travel and then their phone minutes, or things along those lines. The attorneys we talked to from this advisory board felt very strongly that we not say that it be the amount to cover like the average hourly work rate, because not everyone is necessarily allowed to be working who is here. Even though, again, you couldn't identify anyone in our study, they were very careful about how we framed the language for why we came up with the $40, which again was very, very helpful. And then the other thing that they had suggested is that we make the gift card optional, which I know it sounds a little counterintuitive, but they wanted people to understand they didn't have to accept it, in case they were worried that by virtue of accepting it, that would somehow also impact their legal status, or it would show that they had worked, et cetera. And so these were all very helpful kind of considerations that we wouldn't have thought of had we A, not reached out to the IRB in advance, and then B, not had this advisory board that helped think through the actual methods. I think that's mainly what I want to talk about with that study. Yeah, the only other thing I will say about the IRB, I don't know where you, two more other things I want to say are, so Harvard's a weird place, maybe Fordham is too, I don't know, but like, we have something like 30 hospitals, or I don't even know what it is, it's some crazy number of hospitals. And something like 15,000 faculty. I don't really know. And so you're like one of like a million, basically, or one of 15,000. And so there are many, many IRBs and many, many hospitals, and some are just frankly better than others. And so I don't want to encourage you to IRB shop in terms of getting your study through, but I do think it's worth IRB shopping in terms of like which IRB understands what you're trying to do the best, and can therefore like help you actually accomplish your goals the best. And I will say for me, the Longwood IRB, the Harvard Medical School IRB, was vastly superior to my own hospital's IRB. My own hospital's IRB is extremely conservative and doesn't want to do anything that is remotely maybe going to put them in the news. And so I just don't even say I'm affiliated with them anymore. If you read about me in the news, it always says I'm a pediatrician at Harvard Medical School, which is not even a thing. But it's just easier. And so I will encourage you that if you do have multiple IRBs, just to think about which one can help you accomplish your goals best, because some of them are just to have better skills than others, or they have better content expertise. And then the other thing is to understand who is doing. I heard you guys talk about how the IRB is not supposed to scientifically review your study, which they aren't, but you should really understand who is doing that scientific review. Because again, sometimes the people who are doing the scientific review are really actually doing it from a kind of PR CYA perspective, and it's not scientific. Not always, but I will just say, like, I've had studies that the comments that come back from my hospital, again, not from HMS, they're not about the science at all. They're about like, what will this look like if for our hospital if we show this result? And then I just can't handle talking to them anymore. And so just to say that, I do think there are differences in IRBs, and I think the IRB is a wonderful resource. You just have to kind of know your IRB. And the other thing I will say about the community advisory board piece, or community, just any advisory anything, working with a nonprofit, if you end up working with nonprofits, is that they all have an agenda, right? Like they all have a mission statement, which is not bad. It's just that you have to know what that is, right? Like BHR is not the same as the ACLU, which is not the same as the National Immigrant Justice Center. And they have different mandates and different priorities. And so you have to understand the advice that you're getting and who is giving it to you and why. And so just so you understand whether or not it makes sense for you to take it, or if you want to do something a little bit different. Okay, so the second study that we did, so then this whole past year, we have been working on and rolling out this research project. And so Harvard, and you'll see that all these titles are somewhat provocative because they're titled by PHR, which again has an agenda to kind of draw in the news, the media, and policymakers. But this study was about solitary confinement, specifically in ICE detention, and it was called Endless Nightmare because someone described their experience in solitary confinement to us as an endless nightmare. And the reason why it's called torture and inhuman treatment is because the length and kind of amounts of solitary confinement that are being used in U.S. immigration detention right now they meet the UN definition for torture, we're way past it. And so that was where that title came from. And so for this study was actually kind of instigated by a group at Harvard Law School, the Harvard Immigration and Refugee Clinical Program. So a group of attorneys and law students who represent people in their asylum proceedings and other things. And they had heard from many of their clients over the last decade about the amount of solitary confinement that they were experiencing, and they wanted to know more. And so they had actually submitted Freedom of Information Act or FOIA requests now probably 8 years ago to ICE just about general solitary confinement data, like how many people are being placed, for how long, what are the reasons, et cetera. And ICE did not hand it over. And so in the meantime, Harvard Law School had asked our group if we could do essentially kind of almost repeat our past study, but with solitary confinement as a qualitative portion to what they hoped would be their quantitative portion of the study. And so about a year ago, they ended up suing the federal government, sued ICE, and they won, and they were able to get most, still not all, but most of the data that they had requested. And so they had gotten data about solitary confinement from various systems that ICE uses to track solitary confinement. The actual systems are not necessarily that important, but the point being that they actually have multiple systems, which is supposed to make sure that they don't miss anything to track all of this data. They also were able to get some previously kind of redacted reports that commissioned by the Office of Civil Rights and Civil Liberties about solitary confinement. And all the data that they got, you can look up, and the study is all in this Harvard Dataverse, which has been very useful because other people have been using it too now. And then we, on our side, again, myself, our lab had kind of expanded from medical students to now we have PhDs in anthropology. We have a couple of people from the public policy school at Harvard and kind of other multidisciplinary areas. And we interviewed 26 people who had experienced solitary confinement anytime since September 4th, 2013. And the reason why we picked that date is that is when ICE put in this segregation, which is their euphemism for solitary confinement, directive, like the instructions for how solitary confinement should run. In the United States, like when they most recently updated the whole thing. They're currently updating it again. And so we interviewed people last spring and summer who had been in solitary confinement at least once. Again, and the way that we structured the study is that we, again, took ICE's solitary confinement directives and protocols, and we just turned them into questions to basically say, so that ICE couldn't say that we kind of had like a willy-nilly approach to this. And as you can see, it was mostly male, which is not unusual. That's similar to both the general population as well as solitary confinement experiences in other carceral settings. And then a handful of people of other genders, and they were around 35 years old. Again, I'm not going to go into the main findings other than to say there was a lot of solitary confinement. The average length of time was 30 days, and anything over 2 weeks is considered torture by the UN. And People were retaliated against. People were placed in solitary confinement for medical isolation. People were placed in solitary confinement for things as small as like wearing the wrong shirt. It was kind of what you would expect, but we were able to actually document this. And also we were able, through that FOIA data, able to document that ICE's own records were clearly inadequate, like they were not correct, in the sense that when we compared some of their quarterly data to some of the more granular data, the quarterly data, which is the public available data, was vastly underreported to when you actually analyzed it yourself. And so for the, kind of thinking through the ethics of this study, we actually largely copied the prior study in the sense that we didn't ask anyone's names. We only used phone numbers. This one we did not allow, but we more so, because we were having a little bit of trouble with recruitment, encouraged people to, if they knew anyone else they had been in detention with, who might want to speak with us, that they could refer that way. And so we ended up getting several referrals through prior study participants. I will say some of the considerations, again, when I was talking about the system earlier, of this study that was different, is that many people in this study had already been deported. And so in the prior study, everyone had been in the United States. In this study, we recognized really early on, if we restricted to that population, it would be very hard to talk to people. There just probably wouldn't be enough people to talk to. And so we didn't restrict it to any particular, you could be located anywhere in the world. But getting back to my comment about like ethics is nice, but logistics is probably more important. We also learned that it's not as easy to pay someone when they're not physically in the United States, because the way that we had done our compensation in the prior study is that we used Visa gift cards, just cash cards, like these vanilla gift cards, because we want it to be cash, but we also we just want it to be easy to use. And these ones you can just go online and you can either just like use it directly for an online store, or you can just kind of download the cash to whatever cash app you use. However, many of these gift cards are restricted, like you can't use them in lots of different countries because of various money laundering, etc. reasons, things that I don't fully understand, but I generally largely get. And I actually tried calling some of these gift card companies just to understand, or I tried calling kind of some of the vendors that our hospital uses to understand if there was, like, what do we do when we have other international studies, right? Like, what do we do if we like talk to cancer patients who live in Azerbaijan? And they basically said, we don't do that. And so I said, there must be other international studies that aren't like, controversial per se, or that you're like less worried about. And I just kind of couldn't get a straight answer. And then someone even told me like, well, do you really want to go to those countries? Like there's a lot of terrorists. And I was like, I can't talk to you right now. And so he tried to convince me just to not do the study. Anyway, so we were able to figure it out. But my point being that it was really, I was very committed to making, I did not want anyone to not be paid. That was not going to be okay. But there were just like logistical hurdles that we had to go through to figure out how to get everyone the money that they had was given to them, for this study. And so we were able to do it, but my point being that there's a lot of considerations about where people are located and what type of resources they have, et cetera. I think that was the main difference between this study and the other one. Yeah, just make sure. Yeah. The other thing I didn't talk about, because I think you've probably talked about it a lot in other ones, obviously, is just language. We were also very committed to, again, I think I mentioned at the front that everything I do has largely been unfunded. So we've applied for small amounts of monies for these studies, but mainly just to cover the cost of reimbursing participants and then translators. Those are mainly the two costs for the studies that we've done. And for the first study, all of our interviewers, the people who did the interviews were either fluent in English or fluent in English and Spanish, meaning they were native Spanish speakers. So these were usually medical students who were native Spanish speakers. And then we had a couple of participants who did speak other languages, which we were able to get a translation company to to greatly discount their services, so we still paid them, but we were able to kind of negotiate with them. They were like they were an upstart, they were a startup translation company who were trying to break into hospitals, and so which was wonderful, because as you probably know, the hospital translation companies are something like $5 or $6 a minute. And then for the second study, all the interviews, just coincidentally, everyone we ended up recruiting was only either a native Spanish speaker, or we're happy to have the interview done in English because they were fluent in English. And so again, all the interviews were done in the person's native language by native speaking interviewers. So that's, and then the last thing I'll say before I just want to pause for questions is I talked about how, again, for my research, was not necessarily need to be for what you're doing, but all the research we've done has always been in the eye of understanding how it will impact primarily policy. Again, there's lots of other ways to advocate and to help communities, but my lens has always been through policy. And so the reason why we paired with PHR is because we knew that by publishing through a non-academic route, we would get a lot more attention by the people that I want the attention of, right? If you want the attention of academia, then going this way is the wrong way because it doesn't count for anything on your CV. But if you want the attention of the New York Times or Ted Cruz, then you do it this way. And so we worked with PHR because we knew that they had they have someone whose job it is to do media, and they have someone whose job it is to do government relations, things along those lines. And so we were able to get embargoed copies of both reports to various journalists in advance. And this one, I forget where this slide ends, but we were able to get the first study, the one about COVID, to the British Medical Journal, but as well as Democracy Now! Both put out a piece, and then we also had pieces on NPR and elsewhere. And we were able to meet with ICE. ICE did not want to comment on our article in advance, but they did meet with us afterward, and they did. I don't think it's 100% because of our study, there was a lot going on that led to improvements, but I think this study, in addition to other things, helped a lot with the decarceration of ICE during that time. They drastically reduced the number of people in detention, because our main ask was to let people out. Like, you don't need to be in detention. There's no law saying that you have to detain migrants. That's just it's policy, but it's not law. And so, and also conditions were really improved. And then the Office of Inspector General of DHS itself also corroborated our findings, which was very helpful. And then we did, but there is obviously a role for publishing in academia, because you reach a different audience and it has different utility. And so we published kind of the qualitative portion about kind of mainly retaliation, people's experiences in a kind of traditional medical journal. And then for the other study, our approach was similar, but a little bit different, in the sense that we developed much more of kind of a coalition group, kind of going along, so with other immigrant advocacy groups, with other kind of senators or representatives who were already working on either solitary confinement in general, prisons, jails, and ICE detention, or they were working on kind of immigration health policy. And so we talked to a lot of people before we published the study and kind of kept them abreast of the results. And we also, again, sent it to journals in advance, which was great, because the day that our study was published, these two articles in the Times, The Intercept, and I think the LA Times also dropped an article the same day. And so it was very helpful just to kind of get the word out. As you know, you only have like 5 minutes until people forget about what you've done, but it was a very nice 5 minutes. And then we also were able to have a conference locally at Harvard, which is nice because we didn't have the opportunity to do that before. It was in person only, but it was really great because we had the speakers there we had someone who is now an immigration advocate, who had been in solitary confinement himself in ICE detention, who spoke about that experience and about his current efforts. We had a local pastor who currently does a lot of immigration advocacy right now. We also had a local, a Massachusetts policymaker who had formerly been an immigration attorney, but is now a policymaker, talking about what it means to be one versus the other. We had a psychiatrist who kind of first coined the term solitary confinement syndrome in prisons 30 years ago. And so it was a very robust and interesting conversation about kind of how to kind of move policy forward. And then very excitingly, Senator Durbin really does not like solitary confinement. He was mostly interested in getting rid of solitary confinement, which he has been for a long time in prisons and jails, but more recently has also been interested in getting rid of it in immigration detention. So just coincidentally, he was putting forward, not coincidentally, but somewhat serendipitously, he was putting forth two pieces of legislation to end solitary confinement in general. One was for ICE detention specifically, and one was for solitary confinement in other settings. And so they asked us to speak in front of the Senate Judiciary Committee. And so it was myself, a woman from the Government Accountability Office who had just published a report about solitary confinement in the Bureau of Prisons, a sheriff from Texas who argued about why it was important for him to have solitary confinement in his prisons, or jails, and then a woman who had been in solitary confinement in a prison in Connecticut. That might be my last slide. Oh, I'll get to this in a second. But anyway, it was very important, I will just say, like, to have kind of people from all parts of the spectrum kind of informing this effort along the way. And I will just, my last slide is to say, since I don't do any HIV research myself, but this is the first time I've ever been at a conference about HIV, but a friend of mine was a Fogarty fellow studying HIV actually in Uganda. We met in Uganda when we were like 20, and I know he still looks 20 here. He always looked very young, but he was like a whopping 28 here. But he was in a Fogarty fellowship doing HIV research and unfortunately died in a motorcycle accident on the one night he forgot to bring his helmet when he went out, sadly. That's it. Whirlwind.